I would start the scientific extravaganza, for which I would request our young budding nephrologist of the city, Dr. Soumya Gupta, to please join me on the stage. Dr. Soumya is the assistant professor in Department of Nephrology, Motilal Nehru Medical College, and I would request her to start this exciting sessions on nephrology.
Good morning, everyone. I welcome you all on this academic feast, and I feel so blessed and obliged to be here between all the eminent doctors of this city and the stalwarts of nephrology who have basically taught me, and they are all my teachers here. Big namaste to them. Their OPDs. So we will start our academic feast with the most basic, but yet the basis of nephrology, the topic of approach to a patient with renal dysfunction. And to moderate this session, I would like to welcome on stage our eminent physicians, Dr. Piyush Saxena, sir, Dr. G.S. Sinha, sir. So please come on the stage. And Dr. M.K. Mandani, sir. So please grace the dais.
Namaskaram and a very warm welcome to all the delegates and participants. At the outset, such a wonderful CGP, and nephrology is in fact a backbone, and every second or third patient has this sort of a morbidity with it. As it is the season of IPL, if the initial players do well, the team is bound to succeed. इसी तरह से the first presentation is very important, that how to approach a patient of renal disease. If you are able to do that, half of the thing is done. And to enlighten on this, we have a very eminent speaker, Dr. Dharmendra. I'll ask my colleague to please introduce him.
Our first speaker is Dr. Professor Dharmendra Bhadauriya. He is Director, Department of Nephrology and Renal Transplantation, Medical Specialties, Super Specialty Hospital, Lucknow. He has been former professor and head of Department of Nephrology and Renal Transplantation, SGPGI, Lucknow. He has got more than 200 publications, including research articles in the national and international journals, book chapters, and abstracts. He is treasurer of the Indian Society of Nephrology and joint secretary of the Indian Society of Nephrology. And he is icon of health 2019 by Times of India Group, travel grant by WCN. Now, I request Dr. Dharmendra to deliver his lecture.
Thank you, sir. Thank you, sir, for humble introduction. And I'm also extend my gratitude to AMA for inviting me to open this evening. Actually, so this is a very important topic. How to, as Dr. Soumya has already told, this is means coming patient with the kidney dysfunction, either raised creatinine or some abnormality urine is very common for the physician in day-to-day practice. So in this talk, I will try to how this problem we should decipher it. So these are the flow of content, contained. First of all, I will talk what is the concept of kidney damage, what are the markers, then how we should evaluate and then approach. And then I have brought some case capsules to make it more easier. So kidney, whenever somebody is presenting with the either raised creatinine, low GFR, or some urinary abnormality of the protein and RBC, we should approach them systematically, because kidney disease are often silent, they don't throw symptoms. So if you will evaluate them thoroughly, then it is possible that you can detect them early and prevent irreversible damage leading to dialysis and transplant. Your accurate diagnosis can tailor your treatment, and you can provide renoprotective diseases and retard the progression. You can also prevent by diagnosing systematically, you can prevent complication, then you can improve the quality of life patient. You can timely refer these patients for optimizing time of care, and all these things give to cost effectiveness to reduce the burden on the patient and on the system. So coming to what is the concept of kidney disease? So first, there are two things. First, there should be presence of either markers of the kidney damage, either albuminuria in the urine examination or spot urinary protein creatinine, or urinary sediment abnormality of either having pus cells, RBC, or cast in the urine, and imaging abnormality. These are the markers of the kidney damage. I will, in my subsequent slides, I will tell you what are the imaging abnormality which can be the marker of kidney damage. And then the most important is the low GFR. Either it is elevated creatinine or estimated GFR, which we calculate by the simple available equations. Either you can take them on the online, or there are a lot of calculator available, or you can also measure them by the DTPA method, which is a nuclear medicine available in the nuclear medicine department. So how these patients ultimately come to us, how these patients with these problems come to nephrologists. First, there may be some abnormality in the asymptomatic patient. He's just getting the routine investigation and he has some marker of the renal damage, like a 40-year male found to have serum creatinine of 1.5 during the employment checkup. Next, in any patient may have abnormal finding in his blood or in the urine examination, which may be indicator of kidney damage, like invisible hematuria or microscopic hematuria, asymptomatic proteinuria, abnormal constituent of urine, abnormal GFR, raised blood pressure, screening for inherited disorder known to be present in the family, and there may be some incidental electrolyte abnormality like hypokalemia, acidosis, or alkalosis. Patient may come with you with the symptomatic kidney disease, like patient may have urinary symptom, patient may have edema, recurrent hematuria, loin pain, and hypertensive encephalopathy. Or the referral could be in a patient who is also known to have a systemic disorder like diabetes, SLE, some connective tissue disease, getting some drug which is known to cause nephrotoxic. So the person who is treating these patients can refer you. So these are the mode of presentation, either incidental lab finding, like increased creatinine, low eGFR, proteinuria. Vague patient may come with the vague symptom, high blood pressure. Vague symptom, especially nocturia, is very early sign of chronic kidney disease. If you will ask a patient in which you are suspicious of chronic kidney disease, ask the history of nocturia. If patient has raised creatinine and history of nocturia, the diagnosis of chronic kidney disease, chances are very high. Patient may come with edema and shortness of breath. He may have urinary change like frothy urine, which is a very common symptom, bloody urine, or reduced output. So how to evaluate? A good clinical history, as we have all have been taught in since our MBBS time, history which is full elaboration of the symptom, history of risk factor, family history, medication reviewed, and exposure to the heavy metals and other drugs. These are very important. Physical examination should be thorough, as we are all taught. The important is kidney mass or bladder distension you can get on. You don't get much clinical in the clinical examination usually in the kidney patient except pale or edema, and sometimes kidney masses or palpable mass in a patient who have POJ obstruction or ADPKD. You can get sign of systemic disease, especially in the patient of SLE, connective tissue disease, just indicating the etiology of the kidney disease. These are laboratory tests which are the backbone of the evaluation, especially the urinal analysis, which should include dipstick examination. Microscopy is very much important. 24-hour protein creatinine ratio and albumin creatinine ratio, which quantified and rule out glomerular diseases. 24-hour urinary protein creatinine ratio should be done, in which creatinine is important to evaluate to see the validity of the collections. So I just want to give highlight to the microscopy, because urine microscopy is very sensitive test, but it should be done very early after the collection. Means most of the time the urine examination, especially for microscopy, reaches very late, and hence you don't find much finding on the microscopy. Blood tests like urea and creatinine and eGFR are very important for the renal function. One for uremia, electrolytes, CBC, especially anemia and thrombocytopenia can be indicator of underlying kidney disease, and glucose and HbA1c to rule out diabetic nephropathy. We also need sometimes special tests to find out the etiology of the kidney dysfunction, especially autoimmune markers, sometimes paraproteinemias and infectious disease like B, C, and HIV. Imaging is also backbone, especially the ultrasound, in which the normal kidney size actually open the gate, and then you have to be very careful in the further evaluation of the patient. You also require CT MRI sometimes in the case of renal artery stenosis in the tumor, and you also sometimes require nuclear medicine study, DTPA for the measured GFR, DMSA for the scar, finding out the scarred kidney, and dynamic scar to find out the importance, whether this obstruction which is there, it is important or not. And sometimes PET-CT is also important to find out the etiology. Renal biopsy, which is one of the important tools for the nephrologist, and the indication are nephrotic syndrome, rapidly progressive glomerulonephritis, CKD with normal sized kidney. Previously, nobody used to do kidney biopsy in chronic kidney disease, but now with the availability of a lot of renoprotective medication and the immunosuppression, you can retard the progression, especially in the disease of kidney disease because of autoimmune connective tissue disease, or sometimes even in the diabetic nephropathy and IgA nephropathy. So means most of the nephrologists would like to do kidney biopsy with CKD with the normal sized kidney. It is also important in patient of unexplained hematuria and proteinuria, and AKI of unclear cause or non-recovering API especially. It also provides definitive histological diagnosis. You will be sure about the histodiagnosis once you have done. It guides management, especially in the case of IgA nephropathy, lupus, transplant kidney, and it also provides prognostication whether this kidney disease in the advanced stage where there is the treatment may be the futile. So these are the stepwise evaluation for the patient, which I have already talked. So how to note the history and make record? As I've already told, this part, especially the investigation part, always should be recorded serially. This chart is backbone of the all the nephrologists. I have seen even my teachers, Professor Sharma and Dr. Amit Gupta, still using the chart to means diligently filling all the values serially, because this is very important whenever you are following a patient of kidney dysfunction, to especially approach them syndromically. So now coming how nephrologists approach these patients, it's just reverse of the etiopathogenesis. In etiopathogenesis, there is disease which causes some pathology in the organ, especially in the kidney, and then there are symptoms. We approach in the reverse manner. First, on the basis of clinical symptom, we fit into the clinical renal syndrome. Then we guess what can be the pathology in the kidney for this renal syndrome, and then we approach etiology for the etiological diagnosis. What is the cause of this etiopathogenesis, whether this is a primary disease or it is a secondary disease. So this is very important actually. This is the traditional way of looking into the kidney disease when this was taught to us when we were doing training in our institute. So the important clinical renal syndrome are there, you might all well aware. One is the acute kidney disease or rapidly progressive renal failure. Other is the acute nephritis, chronic renal failure, and nephrotic syndrome. So we will study them one by one. And there are also other renal syndrome, especially asymptomatic urinary abnormality, urinary tract infection, renal tubular defect, hypertension, nephrolithiasis, and urinary tract obstruction, which will definitely not the much interest. Especially today, we will focus on this AKI, CKD, nephrotic syndrome, and nephritic syndrome, and RPGRF. So there are changing terminology. Previously, we used to use whenever we used to see patient, we used to use term like renal failure. Nowadays, it is moving that we are now using kidney diseases, especially when GFR is less than 60. ARF has been replaced by the acute kidney injury, and CRF has been replaced by the chronic kidney disease. So if you will look into definition of kidney disease, there are AKI, CKD, and AKD. So AKI, when you have kidney dysfunction in means hours to days, and the diagnostic criteria is only either 2 days or within a week. If the kidney dysfunction is beyond 7 days to 3 months, then we called it AKD. And then the kidney dysfunction is of more than 3 months, we call it chronic kidney disease. When patient don't have history of low eGFR and there is no any marker of the damage, which I have told, albuminuria, urinary abnormality, and normal imaging, you can write no kidney disease, NKD. So now coming to the AKI diagnosing and staging. For diagnosis, if you are following any patient and you know the baseline of creatinine, and you know that there is 0.3 milligram per deciliter rise within 48 hours, you call it AKI. Or if you know that there is more than 50% of rise in creatinine from the baseline within 7 days or within a week, you call it AKI. So these are the two important diagnostic criteria which are dependent upon the duration of the rise of creatinine. Or there is one more criteria which is based upon the urinary volume. Especially this is very much important in a patient who are in the ICUs. When the urinary volume is less than 0.5 ml per kg per hour for 6 hours, if 50 kg person is having 20 ml per hour urine, he is definitely for more than 6 hours, you should think that probably he is developing AKI. Then after the diagnosis, you can also judge the severity of disease based upon how much fold of the creatinine patient has from the baseline, and how much there is a decline in severity of decline in his urine output in subsequent time. So once you have labeled this syndrome as an acute kidney injury, you should further think whether this is a pre-renal cause, intrinsic renal cause, or post-renal. And the most important strategy to rule out first is the pre-renal and post-renal. Pre-renal is predominantly a physiological response of the body towards the hypovolemia, or there is a decreased effective arterial blood volume, especially when patient has congestive heart failure, liver failure, or patient who are on the drugs who impair the kidney function, especially ACE-ARBs, CNI, NSAIDs, and nowadays ARNI and SGLT2 inhibitor. These are the drugs, especially because nowadays there are a lot of use of such drugs in our day-to-day practice, especially in the patient of congestive heart failure and diabetic nephropathy. These all drug impaired autoregulation and which can cause pre-renal AKI. And other important obligation whenever you have renal dysfunction to rule out post-renal, which is this is very important because these are the two diseases, two causes of AKI which are very reversible. They just changing the management can bring out the creatinine down. So just I'm coming with the case number 1 of AKI. It is a 75-year-old female with the diarrhea and vomiting for 3 days. So she has already a volume depletion, and she has all the clinical examination suggestive of dehydration. And if you will see, there is rise of creatinine 0.7 to 1.1 within 48 hours, fulfilling the criteria of acute kidney disease. She also had normal kidney size, and there is no hydronephrosis, ruling out the post-renal cause. And urinary sediments are bland. So this is, if you will look at, this is stage 1 AKI, which is pre-renal because patient has sign of volume depletion, and diagnosis pre-renal AKI due to dehydration. So again, you have to find out 3-step diagnosis: clinical syndrome AKI, pathology, pre-renal, and etiology, the volume depletion. Case number 2, it is a 60-year-old male with diabetes undergoing coronary angiography with the arterial contrast. Nowadays, arterial contrast is only considered a risk factor, not the venous contrast, for the contrast-induced nephropathy. And here you can say there is rise of creatinine from 1.1 to 2 within 1 week. So you can call it AKI because there is more than 50% rise of creatinine. And again, patient has normal kidney size, no obstruction and bland sediment. So this is stage 2 AKI. Pathology is acute tubular necrosis, and the etiology is contrast-induced nephropathy, CI-AKI. Coming to the case 3, in which 50-year-old female who has septic shock from the pneumonia, And here you can say the creatinine is risen from 1.1 to 4 within a span of 10 days. And this patient has a stage 3 AKI because it is more than 5 times from the baseline, and urine output in the 24-hour is less than 0.5, which is 0.3, and fulfilling the stage 3 acute kidney injury. And the pathology is acute tubular necrosis, and the cause is sepsis. Here is the case 4, in which 70-year-old male with the BPH and urea for 12 hours. So this is again fulfilling AKI based upon the urine output criteria. His creatinine is 3.5 times baseline, which is stage 3 AKI. Underlying pathology is ATN, and the etiology is post-renal obstruction. Now coming to the one important actually renal syndrome, which were actually taught to us during our DM training, but nowadays this all probably in the future time it will be replaced by the AKD, acute kidney disease. So it actually we make this diagnosis based upon its subacute nature of decline in the GFR in AKI. The decline in GFR is hours to days, while in the subacute or renal failure or RPRF it is over days to week. And the cause is classical cause is RPGN, which is akin to crescentic glomerulonephritis, in which there are formation of crescents surrounding the glomeruli and compressing the whole glomerular tuft and reducing the glomerular surface area. And other than RPGN, the cause are acute interstitial nephritis, either because of drug and infection, thrombotic microangiopathy, malignant hypertension, cast nephropathy, preeclampsia, these are and scleroderma. These are classical causes of RPRF. And simply you can, again, once you have to find out the clinical syndrome, then you should find out the compartment from where the disease is arising. If patient is RPGN, it means the disease is arising from the glomerulus. Patient will present with the edema, RBC in the urine, proteinuria in the urine, and then you can think of just doing the kidney, means ultrasound. If kidney size are normal, you should think of further evaluation is including the kidney biopsy. If patient is not having the urine having the bland, you should think of non-glomerular etiology, especially the ATI and ATN myeloma kidney. And if patient is started having anuria, having a lot of hypertension, and some means rapidly progressive renal failure, you should also think of vascular causes of thrombotic, means these RPRF. So this is the classical cause of RPRF, RPGN. This is of 3 varieties. Type 1 is because of anti-GBM disease. Type 2 is because of immune complex disease, in which there are many diseases it encompasses, especially the classical post-streptococcal disease, lupus, IgA nephropathy, IgA vasculitis, and third, type 3 is possiimmune, which is because of ANCA antibodies. Coming to the first case of RPRF, this patient is 65-year-old female who started having pedal edema followed by decreasing urine output, and she has rise of creatinine from 1.2 to 4.2 in 2 weeks, mean days to weeks, fulfilling the criteria of the RPRF, subacute nature. And then she also have nephrotic range proteinuria, active urinary sediment, fulfilling that probably that this cause of RPRF is from the glomerulus. And this is how you should approach then. Then further means evaluation is based upon the means either standing the ANCA, anti-GBM, and complement in ANA. Coming to the case 2 of RPRF, in which a 45-year-old male on NSAIDs for chronic backache presented with the history of rash, fever, creatinine risen from 0.9 to 3.1 in 10 days. Again, days to weeks. The syndrome is RPRF, but because the RBC, there are no RBC, urine sediments are bland, there are no red cell, pus cells are only present. Proteinuria is only 1.1 gram, which is non-glomerular in nature, and USG showing the normal kidney size. So it is possibly a drug-induced acute tubular interstitial nephritis, which with just stopping the drug and introducing the steroid can reverse the creatinine. Case 3 is 30-year-old female postpartum presented with oligourian edematous presentation. She also have anemia, leukocytosis, thrombocytopenia, looking like a picture of sepsis, but patient is perfectly all right. It is discordant to the means sepsis, and she's just having the 1 plus protein and bland sediment, and urine PCR is just 0.4 gram per gram of the protein. USG showing the normal kidney size. So RPRF is the syndromic diagnosis, and because thrombocytopenia and anemia there, probably she is having the autoimmune hemolytic anemia because of microangiopathy. So we further go ahead with the LDH and cystocyte in the blood picture, and she turned out a case of HUS, and etiology is complement mediated HUS. Coming to the last important thing is the chronic kidney disease, which especially can be in which there are functional and structural abnormality for more than 3 months. So they can arise from the glomerulus, tubulointerstitial diseases, vascular diseases, cystic and congenital diseases, and disease affecting the transplanted kidney. So coming to the criteria of the chronic kidney disease, so first most important criteria is duration more than 3 months based upon documentation or interference. So if you find marker of kidney damage and then other marker like imaging, urinary abnormality, low EGFR from more than 3 months, you can call it CKD. So one most important criteria is having GFR less than 60 for more than 3 months. This GFR you can either you can estimate by just doing the serum creatinine, or you can sometimes also measure it by DTPA if you are having confusion. And then you should think of marker of the kidney damage other than low GFR. If you can see abnormality in the pathology, especially in the kidney biopsy, you can find abnormal history which is suggestive of kidney damage, especially in the chronic allograft nephropathy, rejection, drug-induced toxicity. You can also find abnormality of albuminuria more than 3 months. You can also find abnormality in the urine of especially microscopic origin more than 3 months. And then you can have abnormal finding upon imaging suggestive of chronic kidney disease. So these are the imaging abnormal finding you can have which are suggestive of chronic kidney disease. You can have chronic pyelonephritis, you can have reflux, you can have polycystic kidney disease, you can have multiple stones which can be the marker of kidney damage. You can also have hydronephrosis on ultrasound. You can have renal masses which is potential to decrease his nephron number. You can also have renal scarring on the DMSA scans. So these are the way to find out the disease damage marker on the different urine serum based on the serum creatinine, urine abnormality, and imaging based. So once you have diagnosed chronic kidney disease, you have to differentiate whether it is of glomerular origin or interstitial origin. So it is just a very important slide to differentiate between interstitial disease patients are usually dry, they are non-edematous. They have less hypertension in comparison of CGN, except few etiology of interstitial origin. The CIN patient don't have hypertension. Most of these interstitial patients, they have bland sediment, and sometimes you can find out a sterile pyuria, only pus cells, without having culture positivity. You can also find out anemia and acidosis out of proportion, because tubulointerstitium is the area where you can dysregulate acidosis and anemia. These patients of interstitial, they are more hypokalemic, and renal osteodystrophy are more common. So once you have find out this is CGN, so you can think whether this CGN glomerular disease of nephrotic origin or nephritic. Nephritic means a lot of RBC in the urine. Nephrotic predominantly in proteinuria kidney disease. And nowadays this is the modern way of looking at the towards the glomerular disease, in which most of the glomerular disease they are divided into 5 classes: immune complex mediated, post-immune, anti-GVM disease, glomerulonephritis, monoclonal diseases, or C3 glomerulopathy. These 5 causes encompasses all glomerular disease of the kidney. Then once you have ruled out CGN, the diagnosis could be CTIN or chronic interstitial nephritis. And these, once you have labeled as CIN, you have to also evaluate these thoroughly, because these patients can be because this disease could be because of infection, could be because of malignancy, especially lymphoma and myeloma, and they can be because of connective tissue disease, genetic disorder, hematological disorder. So these are the steps in the analysis, especially for when you are sitting into the busy clinic, first of all, you should look what is the duration of renal damage. Then, first of all, you should rule out pre-renal, and then you should find out what is the magnitude of renal failure. If means it's a very mild, and then you should go for the ultrasound Doppler and urine test. And if still you are not able to cleanse the diagnosis, you should go for paraprotein and kidney biopsy. So this is step one. Whenever somebody is coming with you with the renal damage, rule out CKD. If you think you have markers of damage or low GFR more than 3 months, it is CKD, definitely they need a different evaluation. Step two, to rule out pre-renal, and you can just treat them with the volume. You can think whether patient should not be on the drug which is impairing the autoregulation. If this renal failure is not, the magnitude of rise of creatinine is less than 0.5, you can just wait for 1 to 2 weeks, because most of the pre-renal diseases, they settle in the 1 to 2 weeks, and then you can further do it. If renal failure is more than this, then definitely you should evaluate it further. And you should go ahead with the ultrasound and renal examination. And if there is obstruction, you have to treat it in that way. If there is no obstruction and urine examination showing the glomerular picture, you should evaluate on the glomerular line of glomerular pathology. If blind sediment, then you should...
I'm after Dr. Dharmendra, you have to
yes,
sum it up.
So, and next is the paraprotein issue, and last is the kidney biopsy. So I'm just, I have some cases based upon this. I'm just finishing them. I think it may be valuable for you all, especially when next time you are evaluating for the patient. Thanks for patient hearing.
Thank you, Dr. Bhadauriya, for your excellent talk on approach to patient with renal dysfunction. The house is now open for any questions, if anyone has any questions.
Does ABG have any role in making the diagnosis or to the approach to renal diseases?
Yes, sir. It can detect, like if a patient is coming with the tubular abnormality, it is a very important role in the renal diagnosing the renal tubular acidosis, especially advanced acidosis of the uremia. It has a role definitely in the management. I think I would say it's a pivotal role. It's one of the important tools in the management as well as evaluation of the kidney disease.
So at what stage would you like to do the ABG?
It depends upon the patient presentation. If means some patient is coming with the knock knee to me, and if he found to have acidosis, systemic acidosis, next thing I will do urinary PS to rule out the renal tubular acidosis. If some like in CKD, the acidosis abnormality and potassium abnormality, they appear quite late, especially if GFR is less than 30, not very early.
Thank you.
Dr. Bhadauriya, you said that ARNI and SGLT can also lead to AKI and pre-renal azotemia. So what you would consider a safe level of GFR to prescribe patients with RD and GFR, because most of the patients who suffer from LV dysfunction have already had some renal insult to them, and the GFR is already a little bit low.
So coming to the SGLT2 inhibitor, the safety limit to like most of the SGLT2 inhibitor is eGFR less than 20. You can start it, and then you can use it up to even 15. There's no problem. But because at CHF, definitely, if we are targeting congestive heart failure, patient is not having diabetic nephropathy, then you can start it well at any GFR. But most of these patients are diabetic. They have coexisting diabetic nephropathy and HFrEF, and then the safe limit to start these SGLT2 inhibitor is more than 20 eGFR, especially. And means they are like, because they are not nephrotoxic, they impair the autoregulation of means GFR in the kidney by manipulating the afferent arteriole or efferent arteriole, especially ARBs, means ARNI and this SGLT2 inhibitor. So, and most of these patients are also getting diuretic. So, so the strategy when you are starting SGLT2 inhibitor, you should first assess the volume part. If patient is already depleted, don't start. If patient is not depleted, on diuretic, you should try to reduce the dose of loop diuretic, and then you should start SGLT2 inhibitor. So they need a lot of tailoring actually.
Over to the organizing team.
Thank you so much, sir, for concising such a vast topic, 30 minutes and in the most simplest way possible. May I request our President, Dr. J.V. Rai, sir, Dr. Ashutosh, sir, and Dr. Anurag, sir, to please felicitate the speaker.